up to a normative model of humanity. So I thought that quote went really well after that video. So for those of you that might be interested in learning more about the social model of disability, Stella Young is a disability advocate. Unfortunately, she passed away, I believe, in 2017. But she actually has a TED Talk that's really, really interesting. And she says things like, I've been an atheist for a long time, ever since I heard that there was only a stairway to heaven. And so she kind of finds ways to bring humor into the realm of disability, and really pushes that she loves her body the way it is and wouldn't change anything about herself, even if other people might judge her for her the way her body is, or the way that she comes across to other people. And so now that we've kind of seen a couple of those videos and thought of different ways to look at disability, I'm curious if your definition of disability has changed now compared to the beginning of the lecture. Have you reflected on any ways that you might have viewed disability, or might have viewed the environment that you function in? Like, is the cafe that you go to, does it have stairs and not a ramp? Is there things that you do, like maybe taking time to help somebody, or the opposite, to kind of stare or observe somebody? Is there ways that we can be more inclusive in our day-to-day lives? And then from what your takeaway from this, how can we use this information to help inform our practice as nurses? So now I want to move into transitions. And so usually by this point, lots of people know exactly what the definition of transition is, depending on the different articles that have been assigned for you guys to read. So transitions are a purposeful, planned movement or change from one position to another. In this case, we're looking at the transition from a pediatric realm into an adult care realm. And so first, I guess we can say, like, why do we care? What does it matter that we're moving from pediatric care to adult care? Why not just move? But there's a huge difference between the way that we conduct pediatric focused care, even in nursing, and then the ways that we conduct adult care. And so even if you think, for those of you, obviously most of you have probably had an experience both in the children's hospital or in like some sort of pediatric clinic and an adult care setting. And so you can think of the different staff that you met along the way, and the differences in the different types of personalities or the approaches to care that they have. One example would be when you are on an adult or acute care unit, how much time does the nurse allocate towards getting a blood pressure reading? And so usually that's, the nurse is expecting in adult care that the blood pressure reading is going to take 20 seconds and that he or she will be able to move on to the next patient or the next task fairly quickly. When we're in the pediatric world, taking a blood pressure, especially on a child that's not familiar with you or a child that has sensory impairments, taking that blood pressure could be something that could take a minimum of 5 minutes. And so the approach to care has to be so different. The other things that I noticed right away from the photos here is that the pediatric care, pediatric hospital, like, it's bright, it's colorful, it's light. The Alberta Children's Hospital was designed with Lego in mind. And so we have a very lighthearted type approach. Whereas the adult world, it's a little bit colder. It's more functional in nature and maybe less inviting in some ways. You guys can think of other ways that you might think that these are different. The other ones I could see is that in the pediatric, we've got 2 clowns, and so that's Sparkle and Jumpa. And Sparkle is actually the first paid clown in Alberta, and she wrote her job description and advocated and got that position. So hopefully some of you have been able to connect with her along the way, whether that's in the elevator or maybe in one of her laughter yoga sessions. The other thing I see is a pool. And so again, we look at pediatric care in maybe a more recreational leisure sense, or maybe value those things more than the adult world might. So in the pediatric care, we are looking at family-centered care, and that is not only it has obviously quite a bit of utility. First of all, if we have a child who's unable to speak, like somebody who's too young to talk, then obviously giving them information on care is not going to be helpful. So we want to give the information to those carers that are going to be supporting the young person uh, throughout their, like in their family setting and in the community. Often in the pediatric setting, it's a one-stop shop. And I always kind of joke about how in pediatrics, it's the only place you'll ever see two specialty physicians in the same room at one time. That would absolutely never happen in the adult care world. You'll be lucky to find two specialists on the unit at the same time, let alone approaching care or in the same room, providing education and speaking with families in the same room. And so again, kind of, I guess on that same vein is that the pediatric world has more of a supportive or team approach. And like I've talked about, lighthearted, it's colorful rooms, activities, toys. Even we have the little bedside, well, I guess South Health Campus does too, but the little day beds that are in the children's hospital. And so a lot of the young people are actually, they have their own room to themselves, and their families are able to stay there if they prefer. And then in the adult world, we're patient-centered care now. So we've kind of shifted away from this family-centered idea into patient-centered. And so there's an assumption that the patient themselves is able to care for themselves and be able to follow through on their recommendations. And so no more one-stop shop. That patient is expected to call and book follow-up appointments. They're supposed to keep a schedule of their appointments. They're supposed to be able to coordinate transportation to and from the appointments. And if you miss the appointment, well, you better get ready to wait another year till the next appointment comes up. And so obviously the adult world's more around efficiency. And so we're trying to get people through. We've got a lot of people to see. And so we don't have time to wait 20 minutes for somebody who might be late because they missed the bus. And so again, why do we care about transitions? What is it that we like so much, that why do we need to concentrate so much on it? And so we're seeing increased, well, transitioning is kind of gaining more focus now because people with disabilities are living into adulthood. So previously, we weren't seeing that many people necessarily survive into adulthood, but now we're not only seeing people live to adulthood, but they're living well into adulthood as well. And so when we focus on transitions, we can provide care to the child or adolescent in an age-appropriate environment. So that means it's also age-appropriate, treatment-appropriate as well. So once we move into adulthood, maybe some of these, like a 4-year-old is not going to be as, like them rooming with somebody who has COPD in their late 90s, maybe doesn't make so much sense. We also have healthcare advances, medical advances, and so different ways that we can care for the population as well as be able to support them well into adulthood. And so a little bit about what I was talking about just now. So increasing number of adolescents are surviving into adulthood, and there is a huge gap in the area of adolescents transitioning to adulthood, which is why I think it's important that you guys learn about it. And so the systemic, organizational, and obviously research realms have yet to catch up. So there's a big gap there. And one of the other reasons that we might want to go about this transition is that there's better treatment options in the adult care world. So it's more treatment focused to the age appropriate for treatment. So somebody getting, like, say, needing support with genetic counseling or getting tested for an STI, for example, that doesn't make sense necessarily in a young pediatric population, but might make sense in more of an adolescent or adult care environment. And then, like I was saying before too, so more fitting to their physical maturation. So having a baby next door to a 90-year-old with COPD doesn't necessarily make sense. And so there's great benefits to having peer relationships and being able to have similar age groups to be able to get that treatment within that environment that's most appropriate to them. And obviously, the other piece is that, as nice as it sounds for a lot of these young people to stay in the pediatric world forever because it's just a softer place to land for them, the beds are needed for the other young people that are coming up. And so in order to have good equity and sharing of the beds, then we need to make sure that our young people are in fact transitioning, even if they don't want to, into the adult world. And so some of the challenges, the reason why there's these big gaps is that we often have uncoordinated services. So we're moving from one healthcare professional to another healthcare professional, and they're often not spending a lot of time passing over that information. So we have poor planning, and that can obviously be both on the part of the healthcare provider or on the part of the family, or both. And so it's not necessarily one person or one group's responsibility necessarily, but that we want to make sure that both are being well informed and being able to move forward with as much knowledge as possible so that they're equipped for this transition. And then obviously lack of acknowledgement. So again, kind of working on that knowledge piece. We also see other challenges that come alongside transitioning from healthcare providers or from hospitals, is that there's other aspects of their lives that are also changing. And so they could be graduating high school, they could be moving out of their home, they could be starting employment, volunteering positions. And so there's like other changes that are happening around the age of 18 that also just make this transition very complex. And so some other challenges are that maybe family or the adolescent is not interested or not as involved in the transition as they could be. And so that could be just that they're not interested. It could also be just barriers like language barrier, for example. And then of course, being scared of the unfamiliar environment of the new location. And so they might just be hesitant just because it is new and it's scary and it's not what they're used to. And so in order to manage this problem, we can look at how to overcome these challenges by integrating the population health promotion model, which I'm sure you guys love staring at. And so that could be a way that we can start just to move through to say, hey, what are some ways that we can actually support people in overcoming these aspects of the transition itself? And we talked about some of this already too. People with disabilities might also be experiencing changes in school settings or day programs. They're changing from funding from Government of Alberta funding in a pediatric realm into an adult care realm. New healthcare team, new care workers, a new location. And so concentrate on different things like skills development, employment, recreation and healthy living, community participation. And so I guess from that, the most likely person to be able to support with this transition is us as nurses. A lot of people think that this maybe is more fit to a social worker perspective, but I think that social workers can also be involved. But I think it's really important as nurses because we are having the most hands-on time, the most kind of FaceTime or interface with our patients, that we are best positioned to be able to support them through this transition. And so for those of you that are less on the philosophical side and more on the give me websites side and want something more tangible, there's different resources that could be helpful that you can check out, you can learn about, maybe you can get brochures from, or just having a list of resources to be able to give families can be so, so helpful. And so whether it's just giving them a list or having a more in-depth knowledge of the different resources that exist, either way, it's important to be able to pass on this knowledge to our families in need of the knowledge. So the first one I have listed here is the Child Development Center. And that one is just adjacent to the Alberta Children's Hospital. It's that building where there's a big handprint on the side of the building. I believe 3 or 4 stories tall. And it's also the Sheldon Kennedy Child Advocacy Center. The Child Development Center is on the 2nd level, and they work at diagnostics for kids with ADHD or autism, for example. And they're able to help quite a bit from a psychiatry as well as developmental pediatric side of things. Next thing is we have access mental health. And obviously, we know that a lot of people with disabilities experience both disability and mental health at the same time. And so access mental health might be an important resource for families to have from a counseling perspective to be able to have that one-to-one support. So that could be both for the parent or for the child or their siblings. Next thing is scope. And scope concentrates on more independent adults with disabilities. They look at more educational opportunities and support from that aspect. Children's Link is a great resource. If there's one thing that you take away from this list, it would be Children's Link, because they have an online database of the different resources that exist around the city. And so even if families just go to the Children's Link website and are able to scroll through and find out which services best fit them, that can be so helpful. And also what's nice about that list is that Children's Link updates it frequently, so it's not a bunch of dead URLs that the family is just going to get frustrated with and move on. The other nice thing about Children's Link is that they work with families up to the age of 20 or who have a child up to the age of 21 years. And so they're able to bridge some of this gap into adulthood. And Children's Link is specifically set up, not exclusively, but is in particular looking to help families who are new to Calgary. And so whether that's just new to the city itself, or maybe people that are new to Canada. And so they're able to provide supports to families who are ESL, and they can provide translation services. And what's great about them is that it's made up of all of the people that work there are parents of people with disabilities. And so they're kind of those people that get it. They've been there, and so they can understand the stresses and some of the, I guess, burdens and joys that come along with disability firsthand. And so that's really great for them. The other nice thing about Children's Link is that they will sit down with families and apply for funding with them, which is really, really rare to find. So Children's Link, they're really, really great. There's also government websites. So looking up in the pediatric world, there is Family Support for Children with Disabilities, or FSCD funding. And then in the adult world, there's Persons with Developmental Disabilities, or PDD funding. And there's quite a bit of information on the Government of Alberta website on how to apply for funding, not so much on the activity, recreation, leisure side, but definitely on the funding side. You'll be able to find lots of information through government websites. And then other resources on the leisure recreational side is Between Friends, as I've discussed before. We also have Easter Seals. You can see the Easter Seals sign in the background here with my client Lauren just standing beside there. And then opportunities like Vokova, which they have the pool just north of campus there, the warmest pool in Western Canada, if you guys want to check it out. It's an accessible pool as well, so it's specifically accessible for people with disabilities, but open to the general public as well. And then we have Abilities Society, Abilities Hub, which Abilities Hub is also in the same building as the Child Development Center on the they're on the third floor. Easter Seals, like I said, and then day programs like Chrysalis or Options, for example. There's also things like DDRC or CAS that families can also benefit from. But a lot of this is just easy to find through a quick Google. And so funding and support opportunities. So we talked about PDD already, the second one in there. The first one is AISH, which is Assured Income for the Severely Handicapped. And this one's specifically a monthly allowance for adults with disabilities or adults that are unable to work for whatever reason. And so this would be funding to buy things like rent, food, toothbrushes, and just general like deodorant, these things that people need in their day-to-day lives. PDD funding is specific to providing support for people with disabilities. So recreational support, maybe overnight support or supportive roommate type payments. And then aids to daily living. So it's a cost share program that helps families gain access to medical supplies or equipment they might need, like railings in their home or like boosters on their toilet seats, for example. And other resources that a lot of families aren't necessarily aware of are things like the Registered Disability Savings Plan, RDSP. And the government will actually match their the amount of money they put in there 3 to 1. And so it's a really, really important thing for a lot of families to get started with. And then the ALIS website, that one can be an important one just to check out, just to gain more information about the different offerings within Alberta. And then different advocacy groups, and obviously any funding grants that people are able to access. And some legal considerations as people enter into adulthood is that once you turn an adult, your chronological age would then determine that you would be able to start making financial or medical decisions for yourself. But in some cases, that doesn't make sense for the population that we're working with. So we want families to be aware of that if they don't want their child to have access to their funding for various reasons, it could be like one client I work with that would rather spend all of her money on gummy worms and chocolate, then obviously mom needs to have a little bit more control over how the finances work and just give her smaller amounts at one time, both for her teeth and for the wallet. And so some of these families, it doesn't make sense for this young person to have access to the finances and to not have a parent have access as well. And so the Office of the Public Guardian will be able to help families be able to decide what is the best call for their specific case. Next thing is employment. So again, as we reach adulthood, a lot of conversations around what happens next. Is it a day program? Is it employment? Is it getting volunteer opportunities? How is this young person going to be spending their day now that they're out of school? And so there's different ways to look at that, but there's disability-related employment supports. And so that could be through a number of different organizations, again, that would be able to either provide support, maybe even short-term, like there is a transition program at Mount Royal that helps people with disabilities get employment, and they support them for the first few months, and then hopefully launch them after that, where they're able to get less and less support over time and then be able to work there independently after a period of time. So from all this, some of the nursing implications that we have, and so we can see that there's this balance between patient and family-oriented care. So we need to understand the needs of the person and the family first, then see how we can support them. So we don't need to assume that they need to go to the Office of the Public Guardian tomorrow, but maybe actually what they need is some respite hours. And so a family maybe needs more of a break right now, and young person needs an opportunity to gain companionship. Or maybe the family's looking for education around things like relationships, friendships, consent, sexuality. And so we want to listen first, just like all of our other nursing, the other things we do as nurses, is to make sure that we listen to the person first, listen to their family, what are their needs, what are the biggest barriers, and how do we present the information to them in the least threatening and overwhelming fashion. So one thing that I always do with my families that I work with is that I can see small problems and big problems, and depending on the level of overwhelm that they're presenting with, I provide them with both verbal recommendations, and then I follow it up by having it all written down, printed out for them. And I often start with, these are the initial ones that I want you to do. I want you to start these tomorrow, next week, in the next month. And then I also give them an envelope of resources that I think would be helpful in the future. And so they might not open up that envelope for the next year, but I want them to give it an opportunity so they don't get so overwhelmed, but that they can throw it in the drawer, and whenever they feel like they need to, they can open up that drawer and take a look inside that envelope and find what the next resource or next opportunity might be for them when they need it. So as nurses, we need to notice the need first. And so I guess from that, we can say, okay, so we have a young person who's maybe 17 and is transitioning into the adult care world. And so we need to know, hey, has anyone talked to you guys about this? Is this a concern for you? Are you worried about it? Have you met the healthcare providers that you're going to be working with in the future? Have you even thought about this area yet? And the hope would be that at 17, they've already started, the ball's rolling on this, and there's already kind of the beginning conversations happening. But hopefully this conversation starting maybe more around the age of 14 instead of 17 or 18, that'll just help with some of the overcoming some of that overwhelm that people experience. Next thing is understanding that each family has a unique experience with disability and with healthcare. And so some of them are very trusting of healthcare and others are not. Some families are very independent and they're able to find resources on their own. They're able to advocate without our support, and others need a lot of support from us to be able to get where they're going. And then to understand that each relationship has different dynamics. And so some family members are more involved than others. Maybe parents are split up, divorced, and so there's communication with both sides of that. Maybe this young person lives part at one person's house and part at another person's house. Or maybe they're intergenerational where grandparents are taking care of this young person. So we have a lot of different assessments to do here, as well as to assess for patient readiness to make sure that the patient that we're working with or the family we're working with are actually ready to hear what we have to say. So maybe we start approaching it one day and over the next few shifts, we start pushing that forward and make sure that we're passing that along in report and doing really good, clear documentation about where the family's at right now, and passing off our recommendations to the next group of people to make sure that we continue having these conversations. And then, of course, being patient as families figure out what the next steps are, and being patient as they navigate what that looks like for them. And so some of the things that I want you to take away from this is that we need to make sure that we're showing value to people, that we're understanding their human rights, that we're seeing that disability affects them in different points of the lifespan, that we're respectful of their self-image and try to approach them as instead of as authority figures, but rather trying to build up their knowledge to empower them. And then again, that'll help them make independent care decisions and to be able to deliver those care decisions in the future. And self-efficacy, so making sure they actually have the information they need for success, and then that they are experiencing value in their setting. So we can create a partnership with them. So clear and attainable goals, write things down, as I said, be flexible, start early, make a timeline to break it down into smaller, more achievable goals. Make sure that you have the right knowledge to be able to take this on. And if you don't, just be honest with the family and let them know that you don't know a ton about it, but that you're going to go find out, or you can look it up together. Make sure that you're recording what's been done and what still needs to be done. Make sure you're talking to your team members about it, and then reflect on it afterwards and make sure that you know what worked well, what didn't, and how to make it better next time. So a couple of things to remember with the transition itself is that the severity of disability makes a difference. And so say we have two people with disabilities, one has asthma and the other one has diabetes, maybe type 1 diabetes, who's insulin dependent. And of those two people, who do you think is more likely to have had a conversation from a healthcare provider about transitioning? And so is it the client with a lower needs or the client with a more severe disability or higher needs? And so the answer to this is that it's more likely, with increased severity of disability, it's more likely that they've had the conversation. The people that fall through the cracks are those people that have smaller disabilities or less obvious or invisible disabilities. So somebody like who has ADHD or who, like I had said, asthma, for example. And those people fall through the cracks, but when they fall through the cracks, they're the ones that don't end up getting follow-up as an adult until things get much worse. And so as a health promotion tactic, we can start exploring some of these conversations earlier so that people don't get to the point of breakdown or having to go to the emergency department before they find care. And other nursing implications, so making sure that we're making use of different services available. So whether that's social work, maybe families have the finances to be able to access counseling, for example, or maybe we have to go through more formal health services. Can we help them manage, like if they're inpatient right now, how are we going to deal with this before they're discharged? And how do we stay connected with them after they're discharged? Or if they're outpatients, when do we see them next? And what's the next steps? And we want to make a plan, and we want to start as early as possible. So I suggested age 14, I think, is a good age. Obviously, it could be earlier, it could be later. A lot of those young people that spend a number of days or months in hospital are not eagerly anticipating the move to the adult world. So a lot of them have had those conversations, and they know it's scary, but we can keep on trying to normalize that as much as possible by having more conversations with them about it. The next thing is trying to make sure that we are taking care of the most urgent needs first, but not ignoring some of these like longer term needs that families have as well. So I have a case study here. I'm not sure if I quite have enough time to go through it, so I can always send this PowerPoint over. I'll just read it quick for you guys, and then maybe you can pause the video or do whatever you'd like to do to try to go over some of the strengths and challenges. So here, my example is Jay is a 17-year-old female with cerebral palsy who uses a wheelchair and is hard of hearing. She lives at home with her parents and her older brother, B, whom she is quite close with. Jay has been struggling with depression and is having difficulty managing her brother's upcoming move to England. B is very patient with her and spends much of his time keeping her company and taking her to the Cerebral Palsy Association where she volunteers. Jay hopes to be accepted into social work at a college at a large nearby city. She currently utilizes a verbal to sign interpreter at her high school, but is unsure what services the college provides to students. So with this, you can reflect on some of the challenges that she presents with, as well as some of the strengths that she has that we can leverage to be able to ensure her success, or at least position her for success. So I have a list of some of the ones that I've thought of. And one of the big determining factors that I've found so important in my experience is when people are motivated to be independent. They're motivated to learn, they're motivated to make goals, and they're motivated to move towards reaching those goals. And so here I have a photo of two people on a tandem bicycle. And the first guy here, he is one of the camp counselors out at Easter Seals. And his passenger here, she is actually somebody who is blind. And when her mom dropped her off at camp, she was very concerned about how her daughter would do navigating a brand new environment, seeing as she couldn't see where she was going. So her mother had a number of different concerns and let me know when she dropped her off that if this young gal needed to go home pretty much immediately, she'd be okay with that. And after a couple hours at camp, she was able to map out the different pathways. She made her way through. She started relying on some of the other campers as well as counselors to be able to help, so she could hold on to their elbow and they could help lead her around. So she kind of let down some of those barriers. And the next day I caught this photo of her on a tandem bicycle, which her mother said would absolutely never happen. And I was able to catch this photo and be able to send it to mom. And she was just in awe with how much growth that her daughter had done just by being set up with having some challenges put in front of her and then just having the support to be able to overcome them. So some reflections on some of the information that you've learned here today. And so I want you to think about what sorts of things stood out to you and what surprised you. Maybe you can think back to the videos, or maybe between the medical model of disability and the social model of disability, but what stands out the most and what's most surprising to you? So I want you to think about how this will all come into play and how it shapes the practice, how it's going to shape your future practice as nurses. I want you to think about how you can integrate some of this knowledge into your practice. And maybe my perspectives are not quite how you would like to practice, but I want you to think about the ways that you want to bring this across and the ways that, or the things that you need to learn in order to be able to support families. So now last is my questions page. And so obviously we can't do that live, but I want to encourage each of you to send me an email if you would like. I'd be happy to answer any questions that you have along the way, even if it's comments, or maybe it's a year from now and you have a patient who has a disability that's a bit of a complex situation and you're curious about what the next steps are. And I'd be happy, if you reached out, I'd be happy to answer any questions that you have. And of course, for those of you that are interested in getting more involved in the disabilities community, I can also be a good resource for that, whether it's through my organization, Enable, or through a partner organization, depending on what exactly you're looking for. Obviously have quite a bit of knowledge of the different resources that are present for people with disabilities and their families in the community. So I'd be happy to share some of that with each of you. And so, yeah, I want to thank each of you for listening. I know it's hard to keep concentration for this long, but I thank each of you for taking the time to time out of your day to be able to listen to what I have to say. And I appreciate all of your attention and the thoughtfulness and reflections that you're going to partake in after this lecture, I hope. And yeah, hope to hear from you soon. And if not, I imagine that Dave might send me a list of questions that a couple people had. And again, I'd be happy to answer whatever comes my way. So yeah, thanks to each of you.